But our next speaker is going to focus on pediatric melanoma. It's my colleague, Dr. Jane Messina. She is our head of dermatopathology, skin cancer pathology. And over the years, she has become one of the top experts in the world on moles and melanoma in children. So Jane, tell us what's new in pediatric melanoma.
Thank you. Thank you so much for this opportunity to talk about really one of the most heartbreaking areas of our practice, but also areas where we've made, on my opinion, some of the biggest strides. So my screen is sharing all right?
Yes.
Okay, great. So I first of all, as I realized when we were first giving this conference and Dr. Sondak was talking about the amazing explosion of cases of adult melanoma, what we're talking about here pales in comparison to patient numbers, and specifically pediatric melanoma is still quite rare. And it's estimated that there may be 500 cases diagnosed in the US on an annual basis. That being said, in certain subsets of young people, especially in the adolescent young adult population from 15 to 29, because of its mortality rate, it is the second leading cause of cancer in that age group. So, what's new about pediatric melanoma? Well, thanks to the DNA sequencing explosion, really just about everything. So it's sometimes hard to talk to a lay audience about DNA sequencing, but I like to try to, make things understandable. And so, first I wanted to explain, why this has become possible for us to study so many tumors' genes. And that's because, quite simply, it's gotten a heck of a lot cheaper since the time that we first decided in the early 2000s that we wanted to sequence the entire human genome. And it took, more than 10 years to actually do that for one patient at a cost of $100 million. Today, it costs only about $1,000 in 24 to 48 hours to sequence an entire human genome. So this is happening in hospitals and research centers around the world multiple times every day. And that's great because a lot of the answers to why tumors start, why some tumors behave worse than others, why some react to treatment and others don't, are in our genes. And in the area of pediatric melanoma, we've just had tons of different things come out in the past 2 years, just to highlight a few of them that have really elucidated a lot of these thorny questions that I've encountered my entire career. Today, I'm going to briefly discuss the role of the pathologist, and this goes for really, pediatric and adult melanoma. I'm going to talk a little bit about the subsets of pediatric melanoma and explain how these scientific developments inform my understanding and treatment implications. So a lot of people know the pathologist because they're the doctor that they get a bill from, and they're like, I never saw this doctor, but actually the doctor saw your biopsy. So we are behind doors analyzing your skin biopsy or your surgery specimen. And our job is stated pretty simply. Our job is to accurately diagnose whether tumor is present, whether it's malignant, whether it's cancer versus benign. If you have a tumor there, to accurately stage it so that the clinical team can know exactly what's the best treatment, and to determine whether your surgery is complete, whether the margins are clean. So our job really starts in melanoma with the biopsy of a suspicious skin lesion. And figures like this are everywhere in the media describing how there are differences between adult melanomas and normal benign or melanocytic lesions or moles, and describing the A, B, C, D, E's and E's of these being evolving change, the differences between these. So that really works pretty well for adult melanoma, but not so well for kids. Pediatric melanomas aren't always easy to recognize. They happen in sometimes really unusual circumstances and presentations, like large congenital nevi, large moles that you're born with. They tend to happen in unusual phototypes, so not the typical light-skinned, red-haired, but darker skin type, so-called Fitzpatrick type 4-5 skin. And sometimes they're not even pigmented at all. So for pediatric melanomas, we only see those A, B, C, D, E changes less than half the time. And while we've certainly increased our awareness of pediatric melanomas, a lot because of this difficulty in recognizing it, a lot of times the tumor is more advanced when it originally is initially biopsied, because it was not biopsied early enough. Biopsies can be accomplished in 3 major ways, and the most common is the shave biopsy. All of these are done in the doctor's office, and can be, the shave and punch biopsy can be accomplished in half an hour, and typically without sutures, while the excisional biopsy often takes a little bit more time and planning and will require suturing. This excisional biopsy is, of course, as a pathologist, what I would love to have on all of my cases so I can evaluate them fully, including the margins, but typically shaves, because they're easier and quicker, are what we receive. And we receive, a specimen that looks like this in a little plastic bottle with some fixative, and then it goes behind the door of pathology, and my animation went away. What happens to it is it goes through a pretty long and complicated process that not everybody sees. So I'll just kind of show, it gets looked at and described by one practitioner. This is the tissue that's actually getting placed in these little plastic containers that have holes in them. So all these chemicals in this processor can flow through them and turn them into a specimen that can be cut. This is a microtome. It's kind of like a deli slicer that can cut that tissue extremely thin. It's then stained. It's made into a slide. This is what a tissue slide looks like. And then it's read by the pathologist. So often, that's definitely at least an overnight process, and many times a 3-day process. And this is what a typical shave biopsy looks like under the microscope. So in terms of pediatric melanoma, how does it start and what does it actually look like? Well, it all starts with a melanocyte, which is the cells in your skin that produce pigment. And this is an actual picture of normal skin showing, here's the surface, and here is the purple line is your skin, and then the pink below it is the squishy dermis under your skin that gives your skin elasticity. And the epidermis skin contains mostly these squamous and basal cells that forms that keratin layer that you exfoliate sometimes. And then here are the melanocytes, these little pale cells. And the effects of sunlight on skin are perfectly calibrated to actually do the most damage where they can do the most harm. So ultraviolet light, which has slightly different wavelengths, UVA and UVB, the rays penetrate about to the level of this part of your skin that is dividing, where the cells are undergoing cell division. And when a mistake happens during cell division caused by the sunlight, then that causes the DNA damage that leads to cancer. So you've got sun shining on these little cells that are containing all the information needed to make normal cells, and it damages them. And when they grow, they make mistakes that lead to cancer. So this is my attempt as a pathologist to make this process digestible to a lay person. And what I have here is actually a skin biopsy that contains melanoma. And I'm showing you the actual melanoma cells. And I'm showing you here what they actually look like on higher power. Think back to 4th or 5th grade, how you learned that a cell has a nucleus, which is the brain of the cell that contains the machinery that tells it what to do. That's the nucleus that the sun is shining on. And this is a nucleus that's decided to divide, that's decided to grow another cell. So this cell has decided to split off into two. So the chromosomes line up here and they divide into two. Those chromosomes, that's what a chromosome looks like, contain, when you unwind them, the DNA that is the site of damage of the sun. And when that DNA is damaged, the cells lose their ability to stop dividing. Multiple different bad things can happen, and typically more than one of these happen. Sometimes these mistakes can tell the cells to grow more quickly, or let them survive in harsh circumstances, or to change the milieu around them so that growth or spread can happen. And the good news is that these changes can usually be seen under the microscope by a pathologist, and that malignancy can then be detected. And in general, the more mutations, the higher the potential for evolution of a cancer. I'm going to break down the types of pediatric melanoma we have here, because these three major types do have some differences in the types of mutations they have, and also the way they present and look on patients. The most rare form of pediatric melanoma is that occurs in those large birthmarks or congenital nevi. And almost all of these have a very specific gene that's mutated. The second largest, shown here in yellow, is the adult type melanoma, that although the ages 14 to 21 are for the most part not adult ages, the melanomas that arise in later adolescence are exactly like adult melanomas. They are mostly related to sun, sometimes related to people with multiple unusual so-called dysplastic nevi, but mostly look like and behave just like adult melanomas, and have a preponderance of mutations in that BRAF gene that you may have heard of, because it's a target for one of our most common therapies. This middle group that occurs in the late childhood, early adolescence is the most vexing type for most practitioners. It's called lesions of the Spitz family. And these lesions are the ones that arise in like the darker skinned people, not typical phototypes, typically no family history, unusual clinical presentations. And the fact that they have distinct genetic fusions is of a new finding that was why I decided to give this talk today. So we're going to mostly focus on these type of melanomas, about which less is known, especially this Spitz family type. So what is Spitz, and where did that name come from? Anybody that's on this call who's had a child with melanoma, or is a child who's had melanoma, has probably heard this word thrown about, because many of the lesions that arise in childhood have a resemblance to the lesion that was first described by Dr. Sophie Spitz. She was a groundbreaker. In 1948, she amassed a group of lesions that had been called melanoma in children and described their unique features and asked, why these lesions hardly ever spread or do bad. And we came to realize is because most of them, in fact, weren't melanomas at all, even though that's what they were initially thought to be. They were actually benign. And we've had a hard time figuring that question out ever since, to be quite honest. Many pediatric melanomas have Spitz features. This is a picture from her original paper showing what a lesion with Spitz features is in black and white. Here's your skin again. And down here, you see the cells that have a shape and size that any pathologist can recognize and say, oh, that's Spitz-like, that's Spitzoid. And so we can all agree when something looks Spitzoid, but in looking at these two different lesions, I have a very hard time, and most people have a very hard time telling which one is completely benign and harmless and which one is going to spread and potentially kill the patient. So I'll just show you right now. This picture on the left is from a completely benign lesion that has a very distinctive genetic mutation. And this lesion on the right is from a lesion on the finger of an 18-year-old that spread to the lymph nodes of the armpit. They look on high power, they look very similar. You have got to look into the genes to try to figure out which ones are going to behave badly or not. And so genes help us understand the Spitz spectrum, and we have learned that the progressive accumulation of mutations defines very distinct subsets. I'm going to throw around some, maybe gloss over some difficult terminology here. What I'm showing is a benign skin, a benign nevus, and the presence of certain fusions, certain mutations called kinase fusions can make a benign nevus happen, but it stops there, doesn't progress any farther, doesn't behave badly, doesn't spread. It's only when additional mutations occur that the lesion can turn into a worse lesion, and we call these atypical Spitz tumor, and additional mutations will turn it into what we call a Spitz melanoma. So progressive accumulation. And this, I'm showing, this slide is somewhat of a duplicate slide, but it's showing that in lesions with a BRAF mutation, the same thing happens, but now we call those, instead of Spitz melanoma, we call them Spitzoid melanomas. If they have BRAF, they're not related to Spitz at all. They're adult melanomas that are mimicking Spitz lesions. So Spitzoid. So it's a little bit of a sounds like a fine distinction, but it's huge in our world. So just to recap, a lesion can have Spitz morphology, and it can be any one of these possibilities. If it has a kinase fusion, it could be either an atypical Spitz tumor or a Spitz melanoma, and only if it has a TERT promoter mutation do we call it a Spitz melanoma. If it has Spitz morphology in any of these three genomic abnormalities, of which BRAF is the most common, it's Spitzoid melanoma. Okay, a lot of words, a lot of terminology. What does this mean for your child? First of all, any lesion that's called Spitz with any uncertainty is a rare lesion, and it must be examined by a dermatopathologist that has experience in pediatric melanocytic lesions. In most cases, we do need additional testing beyond looking at the slide to establish the diagnosis, because of the results of the testing are what's needed to guide treatment. We have a really big alphabet soup of tests that we perform. And just to kind of dissect them here, IHC are immunohistochemical stains that we perform on the biopsies themselves. The next three are tests that are done on the DNA of the skin biopsy, typically at large reference or specialized molecular laboratories. And this slide is probably a little bit too detailed for teaching, but I just wanted to show how we actually algorithmically apply all of these different alphabet soup of tests in trying to find the final diagnosis of a Spitz lesion. We perform immunohistochemical stains. Based on those results, we might elevate the testing to do FISH or next generation sequencing or CGH. And the results of any of those can hopefully help us decide whether a lesion is a Spitzoid melanoma, a Spitz melanoma, or an atypical Spitz tumor. When we do these tests and amalgamate them, we take them along with the clinical history, the appearance, the pathology findings to assign a risk of malignancy. And so a pathology report from a patient that's seen at Moffitt will actually have a big wordy diagnosis, but it'll also have a number from 1 to 5 assigned to the lesion that will hopefully convey to the patient and the parents what we think the risk of this lesion actually being cancer is. And this slide is also, I realize, it's too complicated, but it actually specifically shows you how we use these findings to integrate with all the other features to assign a number of risk, and then how the surgeon uses that risk to guide the treatment. So in summary, the pediatric melanoma arising in kids has different appearances on the patient and under the microscope. We have developed analysis of childhood tumors that have expanded greatly our knowledge of these lesions, and with some changes in terminology. And we integrate all of these features to allow us to make more precise diagnoses and treatment recommendations. Thank you for your attention.